Hi, everybody. Okay, great. So we're just going to dive right into it. I'm presenting Hirsutism. Welcome. So this is just an outline of the talk that I'm going to give. Just a brief introduction. We'll look at some basic physiology, as well as the etiology, and then with regards to the approach to a patient, especially concerning the scoring system. We'll look at the management, and then a nice take-home message. So to dive right into it, what is the definition? So hirsutism is the excessive male pattern hair growth or excessive terminal hair growth. Now, terminal hair growth is that dark, coarse hair, and we say it's in androgen-dependent areas. Now, the only places that don't have hair follicles on our body is the palms of our hands, the soles of our feet, and our lips. Everywhere else is covered with hair, so there are certain areas that are more sensitive to androgens. The axilla and the groin is sensitive to androgen levels, but places such as the chest, the lower back, the thighs, and the buttock, these areas are sensitive to high levels of androgen. So that's why when a patient presents to you with hair distribution increasing in these areas, it's deemed pathological and of the male pattern. So it's the upper lip, the chin, the sternum, abdomen, lower back, buttocks, and thighs. Hirsutism occurs in 5 to 10% of the reproductive age, and it's quite an important diagnosis in the sense that it mostly causes emotional distress for our patients, and it's normally a sign of an underlying endocrine disorder, as Dr. Mbungu said, the most common cause being polycystic ovarian syndrome. We do grade it according to the Ferrelman-Galway score, but we will go through that as it also has some limitations. Now that we know what it is, if we just go back to some basic physiology, so hair is categorized into 3 terms. You get lanugo hair, vellus, and terminal. So lanugo, that is that in utero, fine, unpigmented hair that starts growing around 8 to 10 weeks gestation and is essentially shed off the fetus by 4 weeks postpartum. Then you get vellus hair, which is fine, soft, not pigmented, and essentially covers the body. And then your terminal hair is the hair that we all see, especially in the axilla and the groin, the hair on our head, our eyebrows. So this is long, coarse, pigmented, covers the scalp and the pubic area. Hair growth is a continuous cyclical occurrence and is influenced by many factors, including the blood flow, things like edema, nutritional status, but it's mainly under the influence of sex hormones being androgens. So it's a continuous cycle. It grows in a mosaic pattern. In any given area, we call the human body hair distribution as being in disharmony, in the essence that many different phases occur at once. The entire hair unit, as you can see in the picture, consists of a sebaceous gland as well as a hair follicle. Both of these are sensitive to androgens, which is why hyperandrogenism will lead to excessive hair growth, in the essence that it will stimulate the hair follicle, and then the stimulation of the sebaceous gland will then lead to things like oily, acne, skin in some of the patients as well. So if you look at the 3 phases, it's categorized in the picture. The anagen phase is the most important phase. This is the phase where our medications tend to work, and it's also the phase that all the disorders affect. It is the growth phase. It lasts on average 4 to 6 months for any given part of the body, and it takes about 4 months just for facial hair alone. After the anagen phase, you get the catagen phase, which is the involutional phase. In essence, the hair stops growing, and this is then followed by the telogen phase, which is the resting phase when the hair is shed. So each of these are categorized into 6 months, 2 to 3 weeks, and then 3 to 4 months. But for our purposes, we mostly focus on the anagen phase, which is where our treatment is aimed at. So androgens, what exactly do they do? So these are the functions when it comes to the hair growth. So it stimulates the hair growth, it increases the diameter of the hair shaft, deepens and pigments the hair, as well as increases the proportion of the time of the terminal hairs that spend in the anagen phase, i.e. encouraging growth, and also promotes the growth of sexual hair, in particular in the pubic and the axillary areas, because these areas are sensitive to low levels of androgens. The main sources in females is ovarian and adrenal. Each organ secretes different versions of the androgens and the testosterone essentially, but for our purposes, what's in the blue is what we need to know. The exact levels of the androgens you don't have to know, but just those are the distributions in the blood. With the dehydroepiandrosterone, but mostly comes from the adrenal gland. And then the testosterone, which we look at, is usually ovarian origin. So you can see 1% is biologically active that we find circulating in the blood. 90% is loosely bound to albumin, and most of testosterone is actually biologically inactive if it's bound to the sex hormone binding globulin. The biological effect of testosterone is metabolically converted in the tissue by the enzyme 5-alpha reductase, and it converts it to dihydrotestosterone, which is the most potent form. And then this is just a schematic diagram showing the source of testosterone in the female. As you can see, the ovary mostly secretes testosterone itself. It comes from the ovarian theca cells, and then the adrenal gland also comes into play. This picture helps consolidate when we are looking at the etiology of hirsutism. So what about other types of excess hair? So these conditions don't require investigations from a medical perspective, but obviously they require attention as they can be quite distressing for our patients. So the first is your vellus or your lanugo hair, as we discussed. It's a soft androgen independent unpigmented hair that covers the entire body of the fetus or the newborn, and can also be seen in conditions, especially anorexia nervosa. You see the fine white hairs on the patient's skin. This sort of condition does not require any investigations or medical attention. And then hypertrichosis, I put a picture there just so we can see. So this is the excessive growth of androgen-independent hair that is vellus in appearance and quite prominent in the non-sexual areas, for example, being the face. It's most commonly familial, so it can be inherited, or it can be caused by systemic disorders, in particular endocrine disorders such as hypothyroidism or even growth hormone deficiency, and as well as malnutrition, anorexia. Some medications can also give a side effect of increasing the hair growth in these areas, in particular phenytoin, because we do see patients on that medication. And this is typically managed with hair removal techniques and doesn't necessarily require hormonal therapy. And then unwanted hair is a common presenting complaint that patients seek medical attention. It essentially refers to any hair growth, normally facial, that the patient finds undesirable or bothersome. The hairs are typically not dark terminal hairs. They're rather light, unpigmented hairs, and these hairs can be treated essentially with hair removal techniques because it's not a sign of androgen excess. Then this is just some clarification over hyperandrogenism and virilization. So hyperandrogenism is essentially depicting high levels of androgens in our bloodstream. So the patient can present with things like hirsutism, acne, virilization, or the androgenetic alopecia, which is the male pattern baldness. But important to note that virilization is an extremely rare condition but requires urgent attention as it occurs in severe hyperandrogenism with hormonal imbalance. And the patients, they tend to complain that it's rapid onset of this excessive hair growth, but they don't only present with the complaints of hirsutism or male pattern baldness. They sometimes have other masculine physical traits, which can include things like deepening of the voice or clitoromegaly. So the patient must be fully examined, and it should always alert us to look for a cause of this, in particular in women over the age of 40, because then we start thinking of benign and malignant conditions. So now that we have the brief overview, we can basically accustom that hirsutism is an interaction between circulating serum androgens and the sensitivity of the hair follicles to these androgens, as well as local growth factors being blood flow, edema, and temperature. So what is the cause of hirsutism? It basically boils down to either increased androgen production, increased free androgen circulating in the bloodstream, or iatrogenic or idiopathic. So the table on the left is just a nice table depicting the most common cause of hirsutism and their diagnostic clues. But for us, as approach to exactly like we said, it's either due to increased production, increased peripheral conversion, or increased target tissue androgen sensitivity. So increased production, you already know that androgens come from the ovary or the adrenal gland. So then your first and most common cause is polycystic ovarian syndrome. Other causes from the ovary to consider would be an androgen-secreting tumor, a pregnancy luteoma, or even the hypertrichosis. The adrenal, the most common cause is congenital adrenal hyperplasia and Cushing syndrome. Then the increased peripheral conversion which particularly occurs in patients, obese patients, or patients with insulin resistance. Because remember, insulin resistance basically causes the ovarian Theta cells to increase their androgen production, which can lead to hyperandrogenism. Then obesity also causes decreased plasma binding, as well as other endocrine disorders such as hypothyroidism or hyperprolactinemia. And then increased target tissue androgen sensitivity is essentially boils down to increased 5-alpha reductase activity. Remember, that converts the testosterone into the more potent form. And these causes are mostly idiopathic. So how do we approach these patients when we see them in the clinic? Obviously, we start by taking an extensive history with these patients. Of note, the age of onset is important because remember, you're looking for things like rapid virilization, which is a much higher chance of a malignancy risk. And you also want to find out about peripubertal with associated symptoms, such as weight gain, acne, irregular menstrual cycles. Important to note that after the 4th decade of life, it's very concerning if a patient presents to you for the first time, because this should put your blinkers on to be worrying about an androgen-secreting tumor. Other important histories are any familial disorders, in particular looking for congenital adrenal hyperplasia, as well as their weight history. Have they recently lost weight? Have they recently gained weight? You're starting to think along the lines of polycystic ovarian syndrome. Any associated symptoms in terms of sleep, appetite, mood, also leading you to think towards polycystic ovarian syndrome. And then their drug history, especially anabolic steroid usage, because the adverse effect of this can lead to hirsutism. So after your history taking, we lead on to examination. This is where we will discuss the Ferriman-Galway score, which I'll show you in the following slide. We do this at the initial presentation and the base of our treatment, and we then repeat the score again after 6 months. So with the general exam, important to focus on the patient's BMI. You want to look for things, signs of Cushing syndrome. So what is their BMI? Do they have any abdominal striae? Do they have a moon facies? Do they have a dorsocervical fat pad? Any signs of increased androgen production? Is there any virilization evidence? So you need to look for things like deepening of the voice, for clitoromegaly, as well as increased muscle mass. And then the skin as well. Does it appear oily? Is there any signs of acne? Does she have any acanthosis nigrans in the axilla? And then is there any obvious galactorrhea? Then your actual abdominal exam, you're palpating for an abdominal pelvic mass because it's starting to look for signs of tumor or malignancy. Now, if we look at the Ferriman-Galway Hirsutism scoring system, so this system was developed in 1961 originally and had 11 scoring areas, but then in 1981, Hatch et al. Revised the scoring system as they eliminated the forearms and the lower legs because we found that those areas are less sensitive to androgen levels. So now we use 9 different sections to score according to the hair distribution. We use this as a guide because the score comes a lot with limitations, which are as such. So there's lots of unfamiliarity with the score. We haven't used it before. We're not sure exactly how to depict the level or the degree of hair growth. And many patients have used cosmetic methods before they come to us for their first time, already limiting the score that we give the patient. Some patients actually find that their interpretation of the score is much higher than the doctor's. Then also important to note that the expression of hair growth varies depending amongst the racial groups. For example, East Asian women almost have no hair on their bodies. So when they have a score of more than 2, we're already starting to be a bit concerned. Mediterranean women as well tend to have less hair distribution. So same for them, a score above 10 will require investigation, as opposed to the guided value by the score where we use a score of 8 to 15 with normal menstrual cycle, generally don't need investigation, but a Ferriman-Galway score of more than 15 will definitely require investigations. So there is a modest correlation between the quantity of hair growth and the serum androgen levels, which is why we tend to use the score just as a guide and not as a definite. So what sort of investigations can we do for our patients? So this is being guided by the 2018 Endocrine Society Clinical Guidelines on Hirsutism. Every single case must be individualized and patient-focused and orientated. So there's the scores. If a patient has a score of 8 to 15 with regular menstrual cycle, essentially no investigations are required, and you can follow up the patient in 6-monthly intervals. Anything more than 15 will require an investigation to look for a cause of the hyperandrogenism in the patient. The bloods that they advise, you can do a serum total testosterone. This is one of the blood tests that we do to guide us towards pointing to the diagnosis, in particular looking for an antigen-secreting tumor. The 17-hydroxyprogesterone, when you're suspecting congenital adrenal hyperplasia, just keep in mind that blood test must be done in the morning and it will be elevated. The free testosterone and the serum DHEAS and sex hormone binding globulin is not recommended in the guidelines. However, if you have done it, you can use it to calculate the free antigen index, and this will help to give you a guide towards looking for an antigen-producing tumor. Then with regards to radiological investigations, must be patient-directed. You can do a pelvic ultrasound, especially if you're looking for cysts on the ovaries or if you're looking for ovarian masses. And if you suspect it's an adrenal pathology, then you can move on to an adrenal CT or MRI as directed according to the patient. Other blood tests to do, once again, patient-orientated. If you suspect any other endocrine abnormalities, then you can do things like thyroid, prolactin, or a 24-hour urine cortisol. But this must be patient-directed, and it's not done on every single patient that we see. So now we come to the treatment. So at the initial visit, important to establish your Ferriman-Galway score. What are the desires and wants of the patients? What are their goals as well? To individualize, look for a diagnosis, and treat accordingly. 70 to 80% of these patients most likely have polycystic ovarian syndrome, and that can be addressed separately. Important to note that when initiating these patients on therapy, it must be reviewed in 6 monthly intervals because of that anagen phase. It takes 4 to 6 months for the hairs to grow before you start changing or adjusting the medication the patient is on. The guidelines also suggest pharmacological treatment from the start with this basic approach. So there's always hair removal options, which I'll just give a quick brief slide about as well, and lifestyle intervention. So especially if the patient has a raised body mass index or is overweight, weight loss always helps. We use combined oral contraceptives as our first line treatment for hirsutism unless the patient desires fertility or there's a contraindication. And this is due because it suppresses the ovarian androgen axis, therefore decreasing the androgen secretion. After 6 months of therapy, if the patient has no clinical improvement, then the guidelines advise that you can then add on an anti-androgen, which we will go through some. The combination is not usually first-line therapy unless it is a severe case of hyperandrogenism, and weight loss is always advisable in the patients, and most important for us is psychological support. A lot of these patients have underlying mental disorders because they find it very emotionally distressing, they find themselves unattractive, so always important to do a mental state exam and advise or refer the patient accordingly. So if we go through the treatment options, the hair removal methods. So you have short-term and long-term, but each comes with its own effects. So short-term is most females do shaving, waxing, plucking, tweezing, or threading. Important to note that these patients always advise sunscreen to help with the pigmentary changes. With regards to shaving, it does not make hair grow faster, is a common misconception, but shaving is discouraged in the axilla and the pubic areas, as shaving can lead to a stubble formation, which can essentially lead to folliculitis and ingrowns, which further can cause skin conditions. Then long-term options, these options definitely refer to an expert or dermatologist, but there are things like electrolysis and laser therapy. So electrolysis is extremely painful and time-consuming. In other words, it can take sometimes up to 18 months just before you actually start seeing an effect. It causes destruction of the hair follicle via the electrode, but most patients don't opt for this due to the fact it takes too long before they see any sort of results, and it can be quite painful. Laser therapy is less painful, definitely effective, and can be directed to a particular area, but this is expensive if we think of our population of patients. Intense pulse light is a lighter form of laser therapy, so it's like a light therapy, essentially functions the same way, aims to destroy the hair follicle. And then photoepilation is a much stronger form of a laser that destroys the hair follicles, tends to work better in our light-skinned patients, but important to know that this can actually cause pigmentary changes, which most patients won't be happy about. All of these options can be discussed with our patients, but the side effects can be a bit detrimental in terms of pain, scarring, depigmentation of the skin, and there's always risk of infection. So if we go on to the pharmacological management, remember first line is your combined oral contraceptive. This works well in the essence that it suppresses the gonadotrophins, thereby decreasing the ovarian androgen production. It also helps to augment hepatic production of sex hormone binding globulin, which will then further bind the testosterone circulating in our blood, which would lead to decreased free testosterone in our blood. The anti-androgen effect works essentially at the level of the hair follicle, and the progestins in COC also help by inhibiting the 5-alpha reductase activity in the skin where the testosterone is converted. Important to note with COCs, we want to avoid levonorgestrel because it's the most androgenic progestin, and it's always advisable to use the COCs that contain anti-androgenic pills or non-angiogenic such as desogestrel, cypretone acetate, or jospironate. So these are the common COCs that we tend to use for our hirsutism patients: Diane 35, Dianet, and Yasmin. So Diane contains ethanol estradiol, quite low doses, 35 micrograms, and cypretone 2 milligrams. It is considered one of the first lines of COCs, along with Yasmin, due to the fact that Yasmin also has jospironate, which is a great anti-androgen. The Dianet does contain much higher doses of the drugs. And the problem with Dianet are the adverse effects, in the essence that it can cause liver derangement, so a liver function would have to be done before commencement, and it can also cause risk of feminizing the male fetus and a risk of DVT. So it's important to counsel these patients accordingly, and after 3 to 4 months of therapy, if the hirsutism resolves, then there's always a high chance of relapse if they are on intermittent treatment or if they switch over. So Dianet is normally not the first recommended COC that we use. And then Yasmin, quite commonly tolerated with minimal side effects, but some patients do report breast tenderness, headache, dizziness, nausea. So important to look out for those and just counsel the patients. Then what about our anti-androgens? So the use of anti-androgens will depend on the cost, the availability, and the adverse effects. It's normally used as a second line or in combination with the combined oral contraceptive. These are the commonly used anti-androgens that we find available on the market. The first being spironolactone, used at quite a high dose of 100 to 200 milligrams a day. It works because it's an aldosterone and it's an androgen receptor blocker, and it also helps by further inhibiting 5-alpha reductase activity. They do not recommend using this alone. It's mostly advised to be used in combination with a combined oral contraceptive to elicit maximum effect. It does have side effects to look out for, such as transient diuresis, metabolic, in particular potassium levels, menstrual irregularities, fatigue, headaches, but those are less common side effects, and spironolactone is actually quite well tolerated. Then finasteride, which is also used in treatment of benign prostatic hyperplasia, can also be used in quite a low dose of 1 to 5 milligrams a day. It also inhibits 5-alpha reductase. It has very low side effects, but it's extremely teratogenic, so very important that if the patient is using finasteride, they must be on the combined oral contraceptive. Then flutamide, which is also used in prostate cancer, is a non-steroidal androgen receptor antagonist. It is known to be quite hepatotoxic and can actually turn the urine a bit green. So if we are prescribing this for our patients, it's important to do a liver function before and counsel the patient as well about the hypoestrogen effect. So this drug is actually best avoided, and it's also expensive, so not within our tenor. Then cypretone acetate is used in combination with our COCs, so there are no studies on monotherapy. It does help to inhibit the gonadotrophin secretion, and the side effects are that of nausea and fatigue and a bit of weight gain, but in combination with the COCs, these side effects are at a lesser degree. And then jospironate is a progestin that's used in the combined oral contraceptives, but caution because it's a much higher risk of your vascular thromboembolism. So those are all the anti-androgens that we use for the patients. And then what about gonadotrophin-releasing hormone agonists? So these have been shown to be an effective alternative treatment for hirsutism, in particular when it's of ovarian origin. However, the 2018 guidelines recommend against the routine use of this analog therapy for hirsutism. They say that it can be considered in women that have severe hyperandrogenemia or menstrual disturbances, but it definitely should not be your first line. And then it comes along with the side then this discussion of add back estrogen and progesterone therapy just to try help with the side effects of using GnRH analogs, especially in terms of bone loss and hot flushes for the patients. But the take-home message, it's best avoided. And then the last treatment we have available for patients is topical therapy. So this eflornithine hydrochloride cream essentially works on the hair follicle itself directly, and it also helps to inhibit the 5-alpha reductase activity. It must be applied twice a day by the patient. It is grossly expensive, and the problem with it is the second you stop using it, the hair will grow again. So it's normally not our first or our second line for the patients. I actually couldn't find the cost of it in South Africa. I only know the cost of it in dollars. And it ranged somewhere from $180 up to $200 for one box. And then additional therapy for these patients will depend on their other comorbidities or if you find a cause for the hirsutism. So glucocorticoid therapy is only advised in patients that have congenital adrenal hyperplasia. With regards to obese patients, lifestyle modifications, and we limit the use of the combined oral contraceptives because of the VTE risk. Then the question about metformin always comes along, especially because it's commonly used in polycystic ovarian syndrome, but there's no evidence for use to treat hirsutism on its own. The Androgen Excess and PCOS Society in 2013 actually recommended against usage unless you have a patient that has polycystic ovarian syndrome. Then medroxyprogesterone acetate, quite a strong progesterone, but insufficient evidence to recommend treatment for hirsutism. Mood disorders, and like I say, do a mental state exam for these patients. Don't forget to approach their psyche when it comes to dealing with this excess hair growth, and be very, very cautious in the postmenopausal woman presenting with hirsutism for the first time. So this is just a nice table approach to the premenopausal woman with hirsutism. It's taken off up to date. So it gives a nice summary about the stepwise approach in terms of who to investigate, when not to investigate, and essentially when to treat. So I will just leave that. People can look at it at their leisure. And then our take-home message. So patient education and counseling is important because sometimes patients see their hypertrichosis as being an urgent indication for medical therapy. Fertility desires must always be taken into account, especially as COCs are our first line. And important to remember, not all unwanted hair needs investigations. The Pheromone-Galway score is there of great usage in a guide, but remember it does come with limitations. Always look for a diagnosis, especially in your postmenopausal woman, keeping in mind that polycystic ovarian syndrome occurs in up to 80% of these patients. 6 monthly assessments are required because of the anagen phase of the hair follicle, and most important is the psychological factor. So these are my references, and if there's any questions, I am here. Thank you. And we really should take more of these.
Thank you so much, Kaylin. It was a very well-structured presentation. You did a very good job. I just wanted to go back to the investigations. There's something I want to quickly clarify, especially for the guys that are going for their exam. Yes. So if you see here, according to the Endocrine Society 2018, so they don't recommend your sex hormone binding globulins. But remember, most of the time, the cause of hirsutism is due to PCOS. So you need the sex hormone binding globulins and the total serum testosterone to actually calculate the free androgen index. We actually use it for our patients that are going for ovulation induction as a prognostic factor, especially if your patient is going for load, which is laparoscopic ovarian draining. So you can sort of decide. I think if it's more than 15, I can't remember the value in my head, but if it's more than 15, then you can decide, are you going to do load or you rather do the gonadotrophins? So very important to actually mention that even though the guidelines don't recommend it, but in patients with PCOS, it actually helps us when they go for ovulation induction. Otherwise, it was a good presentation. Any questions for Kaylin? Viju. I see looking at me. Do you have any questions?
I actually wanted to make a comment. I think that the presentation was really well structured. The last time I had a really good presentation on this topic was from Prof. Disfay with very good structure. And it's a very difficult topic to understand, so I think you did very well.
Thank you.
Thank you.
Anyone else?
Any more questions?
Good.
You're Kaylin, you did a good job.
Thanks. Right, we should
So
really
we're
take
not gonna
more of
chase
these.
all the bushes. You know which bush to chase. Okay, thank you.